Life has this incredibly unsettling habit of just changing entirely in the space of a single second.
Oh, absolutely.
I mean, I want you to imagine this scenario for a moment. You were sitting in your kitchen, morning sunlight is streaming in, and you just reach out for your favorite cup of tea.
Right. A completely automatic movement.
Exactly. It is a movement you have executed thousands of times. It requires zero conscious thought. But in this exact moment, something is fundamentally wrong. Your arm simply doesn't respond.
It just feels impossibly heavy.
Yeah, completely disconnected from your intent, like it
Yeah.
belongs to someone else entirely.
And it is a profound and honestly terrifying disconnect because the muscle itself is perfectly fine. The joint is fine.
Right.
But the central command system has just lost its ability to send the signal down the line. Simple tasks that we take entirely for granted, brushing your teeth, getting dressed, even just stabilizing a piece of paper so you can write a note.
Yeah.
They suddenly transform into these daily, exhausting battles.
That is the abrupt, harsh reality for so many stroke survivors. The stroke happens, the acute medical emergency is managed in the hospital, but then comes the aftermath.
The long, really frustrating road of trying to get your physical body to listen to your brain again.
Exactly. And that is the mission of our deep dive today. We are looking into a specific intervention that has the potential to really alter that day-to-day reality for a lot of stroke survivors. We want to understand if a technology known as functional electrical stimulation, or FES, actually helps patients regain functional movement in their arms.
Because it is a question that carries an immense amount of emotional weight for families who are, navigating rehabilitation.
Oh, right.
And that is exactly why we need to strip away the wishful thinking and look directly at the hard clinical data. To do that, we are drawing on a really compelling stack of sources today.
We got some good ones.
We do. We are looking at a highly accessible practical breakdown from an organization called EMS.
Which focuses heavily on supportive rehabilitation technology, right?
Exactly. But we are pairing their practical insights with a deeply rigorous, peer-reviewed, systematic review and meta-analysis.
Right, the heavy hitter of our source stack. This is a comprehensive study conducted by researchers from the University of Birmingham in the UK, and it was published in the journal Systematic Reviews back in 2017.
A really solid piece of research.
The beauty of this particular study is that they just refused to rely on a few hopeful anecdotes. They gathered solid, verifiable evidence from 20 different clinical trials.
Encompassing 431 stroke survivors, which is significant.
Yeah, they did the heavy lifting to give families and therapists real, trustworthy answers based on a wide pool of data.
Okay, let's unpack this. To understand how those 431 patients actually fared, we first have to clarify what this technology is in practice.
Right, because there's a lot of confusion there.
Because when someone says electrical stimulation, the immediate mental image is usually just lying passively on a physical therapy table while a machine delivers random zaps to a muscle. Yeah, that is a very common misconception. And addressing it is crucial to understanding how this therapy actually functions. Not all electrical stimulation is created equal.
Right.
What you are describing is passive neuromuscular stimulation. You lie there, a machine delivers an electrical current, your muscle involuntarily twitches or contracts, but cognitive...
You aren't doing anything.
Exactly. It is useful for preventing muscle atrophy, but it doesn't teach the nervous system anything new. The technology we are focusing on today is entirely different. It is volitional, functional electrical stimulation.
Volitional, meaning it absolutely requires the patient's actual will to move. It's an active process.
Yes, exactly. In FES, small surface electrodes are placed on the skin over key motor points of the arm muscles.
Depending on the movement, right?
Right. That could be the deltoid in the shoulder, the triceps, or the extensors and flexors in the wrist and fingers. But the distinguishing factor, the core mechanism of action here, is that the stimulation is applied while the person is actively attempting a voluntary movement.
So you are looking at that cup of tea, you are putting in the intense mental and physical effort to initiate the reach, and the device delivers a calibrated electrical boost to help the muscle execute the contraction at the exact right millisecond.
Yes.
I tend to think of it like riding an e-bike.
Oh, that's a good way to put it.
Right. If you just sit on a stationary e-bike, it isn't going to drive you to the grocery store like a motorcycle. The motor's assist only kicks in when you actively start pedaling.
Exactly.
The technology is entirely paired with your body's own intention. The e-bike doesn't replace your muscles. It amplifies the mechanical effort you are already trying to generate. In this case, the FES amplifies the biological electrical signal that your brain is struggling to send down a damaged pathway.
That is a perfect structural analogy. The technology supports the physical arm exactly when the brain sends the command to act. What's fascinating here is the underlying biological mechanism of why the specific pairing of intention and stimulation matters so much.
The science behind it.
Right. This isn't just about making the arm move mechanically to achieve a task. It is about Hebbian neuroplasticity. There is an old axiom in neuroscience: neurons that fire together wire together.
Right. If you want to forge a new neural pathway to bypass the tissue damaged by the stroke, you need to create a closed feedback loop.
Precisely.
The brain has to send the signal down, and it has to receive sensory confirmation back that the movement actually happened.
After a stroke, the efferent pathway, the top-down signal from the motor cortex to the muscle, is compromised. The brain yells, "Move," but, only a whisper reaches the arm.
So the arm doesn't move.
Right, and so no sensory feedback returns to the brain. The loop is broken, but with volitional FES, the brain yells "move," the machine detects that intent or is timed to match it, and it fires the muscle.
Wow, okay.
And suddenly the efferent pathway, the sensory nerves carrying information from the arm back up to the brain, lights up. The brain feels the arm moving exactly when it tried to move it.
That's incredible.
It is. Neuroimaging studies demonstrate that this active volitional FES significantly increases blood perfusion to the sensory motor cortex. It increases cortical excitability far more than passive stimulation ever could. You are literally forcing the brain and the muscle to synchronize their conversation again.
You are providing a technological bridge over the damaged neural tissue until the brain can build its own biological bypass.
Well said.
So, knowing that this e-bike for the arm relies entirely on neuroplasticity to rewire the brain, the next critical variable is timing. Because the biological window for neuroplasticity isn't universally open at all times, is it?
No, it isn't. And the data on timing is arguably the most critical and actionable takeaway from the Birmingham researchers' meta-analysis. They stratified the clinical trials based on when the FES therapy was initiated relative to the patient's stroke.
Okay.
And the divergence in the functional outcomes is striking.
The numbers make a massive, undeniable difference. When they isolated the patients who started FES within the first 2 months after their stroke, what clinicians refer to as the acute or subacute phase, the results were incredibly strong.
They really were.
These patients demonstrated statistically significant improvements in their activities of daily living. We are talking about the functional tasks that define independence, getting dressed, bringing food to your mouth, brushing your teeth.
And we aren't just relying on subjective reports of feeling better either.
Right. Let me hear this.
The researchers quantified success using highly specific, validated clinical assessments. They aggregated overall ADL scores, and they specifically analyzed data from the Fugl-Meyer assessment, or FMA.
Which is essentially the gold standard for measuring motor recovery post-stroke, yeah.
Exactly. It's incredibly rigorous.
The FMA evaluates reflexes, the ability to isolate joint movements outside of basic flexor synergies, and overall coordination. It gives a very granular picture of motor control, not just brute strength.
It does. And the meta-analysis revealed that for the cohort starting FES under 2 months post-stroke, their FMA scores showed a statistically significant improvement compared to standard therapy alone.
Which is huge.
It represents a clinically important difference. Applying this targeted electrical stimulation early in the recovery process genuinely accelerates functional motor recovery.
Here's where it gets really interesting. The researchers didn't artificially limit their review to just the early intervention success story.
Oh, they didn't.
They also analyzed the trials involving patients who started FES much later in their recovery journey. In the studies where FES was initiated more than a year post-stroke, the chronic phase, the functional benefits, essentially flatlined.
Yeah.
The aggregate data showed no significant improvements in activities of daily living, and they also analyzed outcomes based on the box and block test.
Right, which is a fascinating assessment. It specifically measures unilateral manual dexterity.
Right.
The patient has exactly 1 minute to pick up small, 1-inch wooden blocks from one side of a partition box, carry them over the partition, and drop them in the other side.
That sounds tough.
It requires a complex combination of reaching, grasping, transporting, and precisely releasing an object.
It demands an incredible amount of fine motor control. And for the over-a-year group, adding FES to their routine didn't produce any statistically significant improvements on that test either. But let me push back on how we interpret this.
Sure.
If you are listening to this right now and you or a parent suffered a stroke 3 years ago, This section sounds incredibly discouraging.
It can, yeah.
Wait, does this mean if you are over a year out from a stroke, all hope is lost? Is the scientific consensus that the neuroplastic window is slammed shut and FES is completely useless?
No, absolutely not. Framing it that way would be a misinterpretation of the clinical reality.
Yeah.
If we connect this to the bigger picture, we have to contextualize this data within the natural biological curve of stroke recovery.
Okay, lay that out for us.
Well, the vast majority of spontaneous natural motor recovery occurs in those initial 2 to 3 months. The brain is in a heightened state of plasticity immediately following the ischemic or hemorrhagic event, aggressively attempting to repair and reorganize itself.
Right.
So any intervention applied during that acute window is naturally going to ride that biological wave of heightened plasticity, resulting in mathematically larger functional gains.
The early group had the wind at their backs, biologically speaking. The therapy is compounding the natural healing process.
Exactly. And when we look at how meta-analyses work, we have to look closely at the limitations of the chronic phase data. The sample sizes for the older stroke groups in these specific trials were remarkably small.
How small are we talking?
In the box and block test analysis for chronic patients, there were only 30 patients total in the FES intervention group across the included studies.
Wow, just 30.
30! That is an incredibly small cohort from which to draw sweeping, definitive conclusions about an entire population.
Yeah, because when you are dealing with a sample size of 30, a minor improvement in a few patients simply won't cross the mathematical threshold to be deemed statistically significant by a researcher software,
Exactly.
even if that specific improvement changes the patient's life.
That is the perpetual tension between statistical modeling and human experience. Small group sizes frequently mask small but clinically vital improvements.
Right.
If an FES protocol helps a patient who is 3 years post-stroke gain just a few degrees of active wrist extension, statistically it registers as a negligible blip on a chart.
But functionally.
Functionally, that tiny gain might be the exact difference between them being able to stabilize a dinner plate while they eat or requiring a caregiver to feed them.
That's a massive difference.
It is. So while the evidence strongly dictates that the acute phase is the optimal window for maximum recovery, we should absolutely not interpret the data as a closed door for chronic phase patients seeking incremental, life-improving gains.
The acute phase is the golden window, but chronic patients can still pry the window open for specific functional improvements.
Exactly.
That naturally leads us to the reality of how scientific evidence is actually communicated to the public. Because, you read those early intervention results, significant improvements in daily living, better motor control, quantifiable acceleration and recovery, and you wonder why this isn't immediately prescribed alongside every single standard physical therapy regimen tomorrow.
It's a fair question.
Right. And the answer requires us to look at the incredibly rigorous and sometimes frustrating framework of how researchers grade their own evidence.
And this is where the true scientific rigor of the Birmingham study is evident. The researchers didn't just publish their positive findings regarding the acute phase and declare the debate settled.
They didn't take a victory lap.
No, they systematically evaluated the certainty of their own findings using the GRADE criteria, which stands for Grading of Recommendations, Assessment, Development, and Evaluation.
And this is a well-known tension in scientific communication. A researcher publishes a paper, and the public sees a label like very low-quality evidence attached to it.
Right.
A layperson assumes that means the technology is a failure. But I have to ask on behalf of the listener, does very low quality mean the technology doesn't work, or that the scientists did a bad job?
It means neither, actually. In the context of a systematic review, very low quality is a reflection of the heterogeneity and methodological limitations of the available clinical trials. It's not an indictment of the underlying technology.
Okay, explain that.
When the GRADE framework flags a review as low or very low certainty, it usually points to specific structural challenges in the research pool. First, as we established with the chronic group, many of these trials had very small participant numbers.
Which skews things.
Small sample sizes inherently lower the certainty score because the risk of a random variable skewing the results is higher. Second, the therapeutic protocols varied wildly from trial to trial.
Ground that for us. What do we mean by varied protocols in the context of electrical stimulation?
Well, the parameters of the electrical current were entirely unstandardized. Across the 20 studies, the stimulation frequencies utilized ranged anywhere from 20 to 50 hertz, and the peak electrical currents delivered to the patients went up to 70 milliamps.
Just to put those numbers into perspective, for anyone who hasn't felt a 10 ns unit or an FES device, a 20 hertz frequency feels like a distinct, rapid tapping or fluttering sensation on the muscle.
Right.
But when you crank it up to 50 hertz, those individual taps blur together into a smooth, sustained, titanic muscle contraction. And 70 milliamps, that is not a gentle tingle.
No, not at all.
That is a robust, forceful, and potentially uncomfortable amount of current grabbing that muscle.
Right.
So you have 20 different studies using entirely different electrical recipes to achieve movement.
Exactly. And some studies focused entirely on stimulating the deltoid to prevent shoulder subluxation, while others focused on the wrist extensors to facilitate grasping.
Apples and oranges.
Right. When a meta-analysis attempts to mathematically combine data from 5 minutes of wrist tapping with data from an hour of intense shoulder contraction, the heterogeneity makes the statistical output incredibly muddy.
Yeah.
But the most significant factor driving that very low-grade score actually relates to the structural difficulty of blinding the trials.
Blinding. Because in pharmaceutical trials, blinding is straightforward.
Very simple.
You give the control group an inert pill that looks identical to the real medication.
Yeah.
The patient doesn't know, the evaluating clinician doesn't know, and the data analyst doesn't know.
Right.
But devising a convincing placebo for an intervention that relies on literal electrical shocks triggering visible muscle contractions, I mean, that is a logistical nightmare.
It is remarkably difficult to design a proper sham control for FES. Only 3 of the studies in the entire systematic review successfully managed to implement a valid sham treatment.
Only 3 out of 20.
Yes. To effectively blind a participant, researchers have to use modified devices that deliver a sub-threshold electrical current. The machine delivers a tiny, superficial zap to the skin, just enough for the patient to feel a sensory tickle and believe the device is active.
But it doesn't actually do anything.
Right. The current is too low to actually penetrate the motor nerve and trigger a muscle contraction. Because 17 of the 20 studies couldn't or didn't utilize this sham method, the inherent risk of bias is elevated.
Which automatically triggers a lower grade score.
Exactly.
And the researchers also highlighted another fascinating layer of bias concerning how the activities of daily living were measured. It highlights the stark divide between subjective perception and objective reality in rehabilitation.
The meta-analysis revealed a critical discrepancy here. When the Birmingham researchers isolated and analyzed only the objective ADL measures,
Meaning what exactly?
meaning scenarios where a trained clinician actively observed and scored the patient performing a specific task in real time.
Okay, got it.
When they looked only at that, the data showed no statistically significant benefit from the FES intervention for the overall group.
Oh, wow. But when they factored in the subjective measures, studies that relied on asking the patient or their family to fill out a questionnaire, recalling how well they had been functioning at home over the past week, the outcome suddenly looked much more positive.
Which strongly suggests a psychological element at play, specifically recall bias.
Yeah, that makes sense.
Human perception, particularly in a high-stakes emotional environment like stroke rehabilitation, is incredibly vulnerable to cognitive bias. A patient knows they're receiving this advanced, targeted electrical treatment.
They want it to work.
They are investing a tremendous amount of physical and emotional effort into the therapy.
Yeah.
They desperately want it to succeed. Consequently, when asked to evaluate their own progress, they genuinely remember their week at home being slightly more fluid, slightly more successful than the cold, objective timing of a clinician's stopwatch might suggest.
It is a powerful reminder of how much psychology intertwines with physical recovery.
Absolutely.
Honestly, a casual reader might look at the very low grade score, the unstandardized currents, the lack of sham controls, and the presence of recall bias, and feel entirely deflated about FES.
I can see how they would.
But I view it from the exact opposite angle. The fact that the researchers were so unsparingly honest, openly dissecting all these flaws and demanding that the medical community fund more large, triple-blinded, randomized controlled trials, it actually makes their underlying findings regarding the acute phase exponentially more trustworthy. They aren't selling snake oil.
I completely agree with that assessment. They aren't burying the methodological caveats in the footnotes to artificially inflate the technology's success rate.
Right.
They are pointing directly at the structural flaws in the current literature and demanding a higher caliber of science. They recognize a highly consistent, mechanistically promising pattern of recovery, particularly for early intervention.
But they want better proof.
Yes, they are insisting on better, more uniform tools to prove its efficacy beyond a shadow of a doubt.
So what does this all mean for the person actually dealing with the aftermath of a stroke, I mean? If we step back from the statistical heterogeneity and the hertz and the milliamps, the practical synthesis is that FES is a tool.
Yes, not a miracle cure.
Right. It does not replace the grueling work of physical therapy. It works alongside normal therapy, not instead of it.
It relies entirely on the patient's ongoing effort. Its therapeutic value depends fundamentally on how, when, and why it is integrated into a broader rehabilitation strategy. The patient still has to show up physically and cognitively.
Yeah.
They still must attempt those movements with intense, deliberate intention. The electrical stimulation simply provides that crucial, precisely timed mechanical assist to help the brain successfully close the sensory motor loop.
The breakdown from ORIEMs articulated this beautifully. They distilled the clinical data into a very pragmatic success equation for rehabilitation. Early action, combined with consistent effort, augmented by smart support, gives the best chance of functional recovery.
It is an excellent operational framework. Early action ensures the therapy capitalizes on the biological window of acute phase neuroplasticity.
That 2-month window.
Right. Consistent effort provides the vital, top-down volitional intention required to physically rewire the neural pathways. And smart support, the volitional FES, acts as the external bridge when the damaged biological pathway can't execute the command on its own.
If you or someone you love is currently navigating the overwhelming, chaotic early days of stroke recovery, this deep dive really empowers you.
It does.
You don't have to wait for the research to reach perfect standardization. You can walk into your next neurology or physical therapy appointment and specifically ask about fitting functional electrical stimulation into the immediate recovery plan, just to maximize the potential of these critical early months.
You transition from being a passive recipient of standard care to an active, informed participant in designing the recovery strategy. But looking beyond the immediate clinical applications for stroke, the mechanics of this therapy raise an important question. Think about the fundamental architecture of volitional FES. We are taking a purely biological internal desire to move, and we are directly pairing it with an external technological intervention.
Yeah.
By synchronizing the human thought with the machine's electrical rhythm, the human brain physically alters its own organic structure. It adapts its wiring to accommodate the machine's assistance.
Which is mind-blowing.
It is. If our brains possess the plasticity to fundamentally change by syncing up with external technology, what does this indicate for the broader future of human-machine integration?
It suggests we are moving far beyond the traditional paradigm of medical devices. Historically, a medical device just braced or replaced a broken part, like a titanium rod stabilizing a fractured femur.
Right, it was inert.
Exactly. But this technology operates on an entirely different level. It is an active dialogue. The nervous system learns the timing of the electrical current, and the machine's algorithms can be tuned to read the specific threshold of the user's intent. We're no longer just fixing the body.
Precisely. We are teaching the biological brain and the external machine to speak the exact same language. As electrode precision improves and the adaptive algorithms become more sophisticated, the boundary defining where human biological intention ends and external technological assistance begins is going to become increasingly indistinguishable.
The technology effectively becomes an extended, integrated component of your own nervous system.
Yeah.
That is a profound concept to leave on. It reframes the entire purpose of rehabilitation technology. Because ultimately, when you're sitting in that kitchen reaching for that cup of tea, the goal isn't merely the mechanical transport of a ceramic mug. The goal is the restoration of autonomy.
Regaining independence.
Right. It is about reclaiming agency over your physical environment, knowing that we are refining tools that don't just mechanically perform the work for you, but actively participate in teaching your brain how to reclaim that physical agency. That is the true promise of where this research is heading.